Okay, if I could have everyone's attention, please. We're going to get started with our second panel here, addressing the unique needs of the housing insecure population. My name is Sally. I'm a clinical psychology student at Pacific University, and so my pronouns are she, her, hers, and I'll be moderating this panel. And we're joined here today by Nora, Chuck, and Pat. I'll have them introduce themselves in just a moment. A couple reminders before we get started. If you have questions, we continue to encourage audience participation. There's note cards and pens scattered throughout the room. And if you do have a question, please hold your card up. We have people that will be collecting questions throughout the panel and bring them down. And then continuing to fill out CE credits if you haven't done so already. So with that, we'll have the panelists introduce themselves, and we'll get on with answering questions. So Nora, will you start us off, please?
Yeah. My name is Nora Olsgaard Wheeler. I'm a licensed clinical social worker, and I'm the program director of STRIDE through LifeWorks Northwest. STRIDE is an acronym for Strengthening Tools for Recovery, Independence, Determination, and Empowerment. It's a transition age youth program specifically designed kind of in parallel and in tandem with the ESA program. So it's funded primarily through OHA, as well as some insurance coverage. But we provide transition age youth skills. Our target populations are 14 to 25-year-olds, folks who are experiencing homelessness, folks who are identify in the LGBTQ population, as well as folks who are exiting foster care or larger systems of care. So very, very marginalized populations that don't necessarily fit within the traditional buckets of child and family or adult services. Our model is the TIP model, so it very much focuses on kind of a similar model to assertive engagement. We have therapists on staff as well as peer support specialists who are kind of the magical unicorns these days, and then case managers. That's STRIDE, and that's me.
Hello, I'm Chuck Savy. I'm an acupuncturist and a crisis counselor and a medical education coordinator at Old Town Clinic, which is a primary care clinic, and it's part of a much larger organization called Central City Concern. Central City Concern's mission statement is to provide pathways, solutions to help move someone out of homelessness and poverty towards self-sufficiency and empowerment. And we work in three areas: housing, health and recovery services, and employment. I've been around for about 40 years, one of the largest nonprofits in Portland, and I've been there for about 16 years. And I'm glad to be here. Thanks.
Hi, everybody. My name is Pat Buckley. I also work for Old Town Clinic. I am a 2009 graduate of OHSU's PA program and a 2002 graduate of the National University of Natural Medicine. Depends on how I view it. I've been at Old Town Clinic since January of 2008, which would put that at 11 years, working with my mentor you'll be hearing from, Barbara Martin. So I kind of consider that my start date, but they didn't start paying me until September of 2009. And that's when I started as a primary care clinician. And over my time there, the agency and particularly our clinic has morphed a lot. And I kind of eased into urgent care and then started doing some wound care. And we opened some satellite clinics. So I started working at our Bud Clark Clinic, which is an acute care clinic housed in Transition Projects Day Center, or now the Resource Center. So I've been working there for a couple of years, and then in the spring of this year, we opened a new program in concert with Transition Projects. It's called Health Connections, and it is a combination of the Hansen Clinic, which is basically anybody who is staying at the particular shelter we're housed in can come and get any kind of medical care, or they get sent out to the hospital if I don't think I can handle it. But we also have 15 beds that are designed to be a long-term location for people with chronic illness. So I have people who may have gotten out of the hospital because of a recent congestive heart failure problem or out-of-control diabetes with wound care needs or COPD. We have a number of different people with a lot of different chronic conditions there, and I do everything from acute management or wound management with them to complete primary care facilitation so that they don't with their complex needs, they don't have to get on the MAX and go all the way downtown in order to get care, or to Providence or to Adventist, wherever their primary care is. I'm facilitating that care. So it's pretty comprehensive. It's been one of my privileges in this job. Glad to be here. Thank you.
All right, thank you so much for those introductions. Just a quick sound check. Can everyone in the back hear me and hear the panelists? Awesome, thank you. We got some feedback, so we wanted to make sure everyone's hearing us loud and clear. All right, so we'll get started with the first question. Are there any unique health concerns that might be specifically addressed in this population? Nora, we'll start with you if that's okay.
Yeah, I think I view Stride's services and supports through a mental health lens, so that's my bias. I think in conjunction with that, and kind of thinking about the previous panel that you all just had time with, also the specific needs for our transgender youth population, and specifically those folks who are experiencing homeless on top of all those things. So I think providing services through a trauma-informed lens and really meeting people where they are at, as opposed to making people kind of jump through these hoops to access services. I think there's a lot of compassion in that. And we're just seeing more and more complications through social media and through barriers that are put into place by systems of oppression for LGBT youth in accessing the support that they need. So from my lens, I think there's always more we could do for the mental health support with folks, and how much that would alleviate our physical health.
So these may not be unique to someone who's experiencing homelessness, but it's just the things that I see often. I see everybody's anxious, everybody's stressed, everybody's in trauma, current trauma, past trauma, future trauma, infections, wounds, head injuries. Many people are experiencing traumatic brain injuries and may not be recognized, may not be diagnosed, and just the behaviors that come from that. Poor sleep, mental illness, addiction, just straight up exacerbations of chronic illnesses, just how difficult it is to manage when you're on the street and you don't have a safe place to be. Due to living outside, you just get sick faster and you stay sick longer. According to the National Healthcare for the Homeless Council, health problems cause 62% of all the personal bankruptcies in the U.S. People experiencing homelessness die on average of 30 years earlier than housed individuals. 30 years. I mean, that's always trips me out. I mean, that's a huge number. And we see that every day. We see folks that are just dying really early. Without homes, people experience illness and injury 3 to 6 times more than housed individuals. So, yeah, I mean, it's just really difficult, and it shows up in illness when you don't have a place to be.
Thanks, Chuck. So I concur with really everything that Chuck just said. The couple of things I would add is the problems are extensive. They really are. And the risk for getting new conditions or exacerbating chronic conditions is super high, obviously increasing during the winter months more so than the summer. And one of the things is the combination of exposure to moisture and cold really increases the risk for cold injuries. We see a lot of immersion foot or frostbite. I'm working with a wound care person who has frostbite right now, and he has very difficult time getting into. Are you guys all familiar with the different kinds of shelters? Because there's all different kinds of shelters. There's like the Mission, where you go in around 6 o'clock at night and you're out by 6 o'clock in the morning. You do not have a place to stay during the day. You do not have a place to leave all of your belongings. There are also more long-term residential shelters, which have a limit on how long you can stay, but it is a place where you can leave your things and they're safe and you have a place to come back to. There's often a place where you can stay during the day and hang out. And then there's places like the Transition Projects Resource Center, where you can go and hang out during the day and get some of your needs met. And I have a patient right now, he's got frostbite, and he has very difficult time accessing the overnight shelters. We're trying to get him into one of the long-term residential shelters, but his mental illness is complicating that right now. And so his frostbite isn't getting any better because he's exposed to the cold repeatedly. It's not getting worse because the temperatures haven't been cold enough for his frostbite to get worse, but he's not going to get better, and the risk of his decompensating over time is it's a much greater risk than somebody who is housed or has access to be inside for more hours of the day. The other thing that's a big increased risk is communicable disease. So a lot of these people have higher risks for tuberculosis. They have higher risks for the flu if they're not getting primary care and getting flu shots. Any of the things that are running around, including little friends like lice and scabies, tends to run through circles. And that's a big thing that we have to deal with on a regular basis.
All right, thank you so much. Anyone need to add anything? Or okay, we'll move on to the next question. What do you think is our role as practitioners in advocacy for this population, both at the individual and systemic level? And Chuck, we'll start with you this time.
When I thought about this question, it's really up to you, and what your personality is and what your skills are. And it can be really difficult to talk to folks sometimes about homelessness and about the struggles that people are going through. At least for me personally, I struggle sometimes with the judgments that come. So helping others understand the suffering and challenges and barriers to change, if that audience is receptive to kind of going into it and really looking at it and talking about it. I do a lot of educating. I work a lot with students. I work a lot with just different folks coming through our clinic as part of their education. And whatever opportunities I can have to advocate for increased services. So, being at a panel like this or talking to politicians, or I do quite a few tours and kind of orientations to services to community partners and community members and donors and such. Any way that I can try to help explain some of the context so that I can hopefully increase some empathy about people that are sleeping outside and what that really could look like. And I always try to talk about something. I don't know if I'm always effective about it, but think about if I gave each of you $1,000 and you no longer have your home and we're all going to be homeless together tonight, and what that could really look like, and just how quick that money would go and what you would do with that money. I mean, I would get high. I would be high really fast because I would want to stay awake all night. I'd want to be safe. I wouldn't want to get assaulted. And someone may still jump me and I may lose some of that money. And then what am I going to do? And I've already tried to be inside a few times and it's been really a difficult road. So it doesn't take long to lose all that money. And then what are we going to do? So it's just a really challenging dynamic to come out of, especially if you don't have the kind of social support that I assume most of you in this room probably have, to kind of that sort of social capital. So finding some way also to kind of walk with people in this dark tunnel that they're in and be maybe some light for them, some hope, to kind of walk with them. It's not so much that I fix people's situations. I just try to stay as close as I can and see how I can help.
So, like Chuck said, it really depends on the person that you are and what you're willing to do. On an individual level, support the local agencies that do the work that we do, and recognize the barriers that people have to face, and treat those who are in this position with as much kindness and respect as you can muster. One of the things that a patient said to me the other day is, he knew when he met me and one of my coworkers at our Bud Clark clinic that he said, I knew all you wanted to do was help, that you were there to help me. There was no judgment involved. And that allowed him to move to the next place, and now he's in our Health Connections program. So because I didn't have judgment about the fact that he was high and he was diabetic and he needed insulin, I just gave him the insulin. And I asked if there was anything else that he needed. So that, as an individual, is one of the best things we can do. And then, if you're so inclined, I am not a political active person. It's not my thing. It's not what I like to do. I'm happy to do things like this, but I'm not a mover and a shaker. But if you are a mover or shaker, please move and shake. Move and shake as hard as you can, because we need the advocacy. We need people to advocate for ways to improve housing access. I mean, just looking at, in the 22 years I've lived in Portland, what has happened from rents when I moved here, when I could get a house with 3 bedrooms for $800, to what it costs now for, you can't get a studio for $800. So the access to affordable housing is a very, very big barrier that a lot of our people face. And again, it's just about meeting people where they are with as much kindness and respect as you have. I have a mantra that I live by. I've been living by it for a couple of years, because what I can do is I increase love and I decrease suffering in my corner of the world. And sometimes that's just smiling at somebody and saying, I'm sorry, I don't have any change. But at least I did that on Hawthorne one day, and the guy just looked up at me and said, thanks for at least acknowledging I'm here. And a lot of our folks are just not seen. And sometimes I see somebody and I get a lot of crap for seeing them and not doing something. And that's okay too, because that's where they are. And I just let it roll off my back and I move on.
Yeah, I think the two things that come to mind for me is the importance of rapport. I think rapport is often a step that we simplify, because we are all about like finding solutions and getting people in and out of the door as quickly as possible, not in a malicious way, but in a reality way of there's always people to be seen and there's always stuff to do in our world and in our work. So I think having some pause buttons in the day where we can connect with individuals on a personal level, and they get to see us as people just as we see them as people, provide some transparency that can go a really long way. I think the flip side of that, and this is me as a social worker speaking, is I think taking care of ourselves and not like burning the candle at both ends. So incorporating self-care, incorporating worlds to fill up our gas tanks, metaphorically speaking, so that we can sustain in this work, because there will always be systems of oppression, and there will always be opportunities for folks to help individuals if we can get there.
All right, thank you so much. If it's okay with you, we have a question from the audience, so we'll pitch that. Where are homeless, hospitalized individuals discharged to? How does this work? And Pat, we'll start with you if that's okay.
That's a really good question, because sometimes it's done really well and sometimes it's done really poorly. We have a program through CCC. It's called the Recuperative Care Program. And that is a place that provides normally 30 days post-hospitalization. There is a process for getting in there. It needs to be arranged through the caregivers at the hospital and social work. There's an intake process, and there's always, well, I shouldn't say always, but there is very often a line for a bed. So people are taken on acuity versus first come, first serve. Very often, people are just discharged to the street. I recently saw somebody at our Bud Clark clinic who he had a damaged spleen. They did a surgery to repair his spleen and then sent him out to the street with his 50-pound pack, so that he ended up back in the hospital a few days later, and they had to remove his spleen because it had, all of the stuff that they had done had broken from his carrying around his 50-pound pack. And then they discharged him to the street again. And fortunately, there was, as I like to say, there was room at the inn. And so I made some phone calls and I wrote some letters and contacted a bunch of people so that an intake could be done, and got him into the recuperative care program so that he could heal from the 14-centimeter incision across his abdomen that was stapled closed. And he got sent out to the street with a 50-pound pack. So it's not always something that's thought through, and there are resources available. One of my patients who is at Hanson, or at Health Connections right now, came to me through Kaiser, and Kaiser was kind enough to put him up in a hotel for about a week while they worked out the details to get him in with us. So advocate, 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 because there are resources out there, but they're not a lot. And it does take a lot of advocacy from the beginning to get access to something.
Yeah. Discharges are hard. Folks leave AMA, or they leave before, or they'd like to stay longer because they get a shower and they get meals. And if hospitals have space, sometimes they can accommodate that, and other times they can't. Or they're stuck in the ED for multiple days because there are no beds in the hospital to be seen. So yeah, people get discharged to, we often at Stride will get phone calls saying, hey, this person discharged 2 hours ago. This is their phone number. This is the Starbucks they generally hang out at. Hopefully you can connect with them. And I don't think that's malicious on the hospital part. Those are complicated systems with people paid way more than me, and insurance companies who are eventually making the call. And so I think we as providers have to adapt and adjust, and again, just try and meet someone where they're at, knowing that systems will always let people down.
I remember when recuperative care program was created, and I think about all the changes that I see with hospitals, at least some effort to really look at discharge, really look at aftercare, especially for someone who really is difficult to connect to aftercare. So I see a lot more work going in. You know, we have folks that come by the clinic that are, you know, helping people just make it to that appointment after the hospital. And that's so key because, and I think it's mostly financially motivated initially. You know, they, if that person doesn't connect to primary care, doesn't connect to aftercare, they could readmit, and it could be a much worse situation and very expensive for the hospital. Some of the great pieces of the recuperative care program is it's not just a bed that you're in, it also has social work support, it also has nursing support, it has people that are really going to be there to help you recover. Kind of like I think might happen for most of you if you had some kind of fracture, infection. You have friends who would make sure you got your antibiotics, make sure you make it to appointments, help you not get too depressed. That's a bit of what RCP is about, and that's amazing. And their barrier is very low. It's in one of our low barrier buildings, so I could still use illicit substances. I could still be drinking, but they really want to try to get this wound healed up or this fracture healed up. It's an amazing program. So more things like that, and it saves the hospital a ton of money because that month in our building is nothing compared to keeping me in that expensive hospital bed. So, yeah.
Great, thank you so much. So we'll move on to the next question that we had ahead of time. What are the top concerns a practitioner should have when communicating with a patient from this community? And Nora, we'll start back with you again.
Sure. I think I think about this question in regards to kind of our LGBTQ youth who Stride sees pretty frequently. So I think a lot of what I would say was spoken about in the last panel, but pronouns, chosen name, and then also what their natural supports look like and who they identify as family. I think family can look really different to a lot of different people, but in order to make a successful transition plan and supports, I'm going to need to include those folks. And sometimes those are also homeless youth. So it gets a little complicated, at least for the Stride side of life. But again, trying to meet them where they're at and support their identity as they continue to further understand it.
I think some of the top concerns that I think about and try to explore with the patients that I see are medical literacy and just overall literacy. Like, how much are they understanding what's happening and what's going on? What are their priorities? What are they really interested in? You know, I have some ideas. You know, there's some real serious things going on that I'm seeing, but for them, they want a bus ticket to get to this pawn shop, to pick up their guitar, to get this or that. Like, just figuring out, like, what is really motivating this person that's in front of me. Safety, you know, like what's their world look like right now, and how safe do they feel? I'm all about building trust and relationship. Like Nora mentioned about rapport, that's huge, you know, and just the last gentleman in the panel talked about just slowing down, you know, just taking that time with folks, identifying support. So getting a sense of just who are their people around them and what other connections to services do they have. So I'm all about trying to collaborate and figure out like what's been working for you. Like where do you, because for some of the people that come into our primary care clinic, they're going to multiple other places and they're receiving help. And I'd like to be familiar with what that looks like. Attempting to have a non-judgmental presence. Just always working towards that, noticing for myself when I fall down on that. And what is that about? And do I need to educate myself in certain areas, certain things? Because it's not simple. I mean, it's a really hard thing to maintain. And just continuing to kind of strive for that. Pay attention to the nonverbal communications, my own and others, because I see a lot, you know, especially so many of the patients I work with. Trauma is a huge part of their world, and it's all over their body and how they act. And that can give me a lot of information on how to kind of further our relationship and connection.
So ditto what everybody else has said. I would have to start with don't make assumptions. It's really, really easy to make assumptions that somebody's going to understand what you're putting out. They're going to have some similar background or similar experience, and I don't know what somebody else's experience is, so it's really important for me to not make those assumptions. There was an assumption I had up until a couple of months ago where I thought everyone would do better if they were housed. Everybody should have their own space. Everybody should live alone in their own space or with their chosen person. And then I watched Health Connections, and I watched a community grow up among a bunch of men who were supporting each other in a way that I had never imagined a group could do or a few individuals could do. I remember I had changed some inhalers for one of the guys that had COPD, and I hadn't seen one of the other people. He was relatively new, and they were sitting kind of comparing notes, and one guy was turning to the other going, "You should really talk to Pat about this inhaler because I think it'll be really helpful for you." And they were doing this supportive thing that it just didn't occur to me would be of benefit. So what I think is best for somebody isn't necessarily the best thing. And listening. One of the things that I try and do, just because of how my brain works, I get really, caught up in all of the different things that have to be done for a particular patient at in the visit. So I'm, saying, can you please fax this thing over or call this person or make this appointment for so-and-so? And then if I just run into the next room, all of that baggage is coming with me. So I always stop and take 2 breaths outside the door. It's all of about 10 seconds of my time, but it allows me to kind of let go of where I was and be ready for what's in front of me. Because my last visit could have been great, and this one's not going to go so good, so I don't want to bring that expectation. My last visit could have been awful, and I don't want to bring that attitude into my next visit. I want to be fresh and present for the person that I'm seeing right now. And if I can do that, that's like the biggest part of my own self-care is to not carry client to client to client throughout my day. What else? Just basically meeting people where they are and don't have assumptions.
All right, awesome. Thank you so much. We'll move on to the next question, and we'll start with Chuck this time. How have your health recommendations had to change or become more creative to increase adherence to treatment plans? And how do you prioritize health outcomes in these populations?
So since I work at a primary care clinic and I work with multidisciplinary teams, I was asking some other providers, some other questions, some of these questions to get their input and stuff. And some of the things that came up was really thinking it through, like medications and the medications that you're giving someone. Does that medication need a certain amount of food? Does that medication safe in certain amounts? Because for some of the folks I work with, if they're holding a bottle of pills, that can put them at risk of assault, of just thinking through some of that stuff that you might not need to think through if somebody has a home, if somebody has a safe place to secure things. Lowering barriers around appointment times, you know, you just got to, or you're just going to get frustrated. And you don't have to. I see other systems not doing that, and they just don't see folks that are experiencing homelessness. And behavior expectations. Just really trying to suss out, like, yeah, it's just, some folks are going to act very belligerent. They're going to act very aggressive verbally. And it's just part of what they're going through and part of what's going on. And we can still be safe as providers of medicine and still figure it out with some skill building and some ideas. A seemingly simple complaint can be just so much more difficult to resolve when somebody's not housed and they don't have a warm place to be. So just kind of thinking of the work we're doing as more marathon-like with some things that may get resolved much faster in other situations. Harm reduction, continue to ask questions, just trying to get a sense of where somebody's really at, what are their circumstances. Connection is healing. And I really believe strongly that compassionate, caring relationship is one of the best treatments for trauma. Just that consistent, predictable kind of dynamics. And that's part of what we try to, as best we can, embody at the clinic and with our interactions. Sometimes if you really do start to connect with people, though, it can be very heartbreaking and it can stir up a lot. So back to something that's seemingly simple like self-care is so important and can be very difficult and complex for us as providers at times. Yeah.
So one of the things, I do a lot of wound care in addition to my urgent care. So one of the first things I ask is, where are you staying? I don't say, where do you live? I ask where you're staying. Because sometimes it's at, 5th and Stark. Sometimes it's at a camp. Sometimes it's at a long-term residential shelter. Sometimes it's at the Mission. So part of my thinking process when I'm trying to decide how I want to prescribe is, what are their circumstances? Knowing that lets me know the next thing is, how easy is it to take multiple pills in the course of a day? I rarely prescribe penicillin because penicillin normally has to be taken 4 times a day. And I had to take medicine 4 times a day for like 2 months, and it was possible for me to do it. I had to set an alarm on my phone. I had to carry a bottle of pills with me. So long before I had my personal experience, I was not prescribing 4 times a day if it was possible to avoid it. So minimizing the number of pills, minimizing the number of prescriptions when possible, talking to people about, do you want to come in here and pick up your meds? So that I can set it up as maybe a daily dispense through the pharmacy. There are several pharmacies in town that will do that. If you call up and ask them if I can write a prescription for, 2 pills with 7 refills, so that somebody can come in every day to pick up their medicine. One of my patients told me recently, because I was talking to him about a wound care lecture I was doing, and it's about what somebody's carrying with them. Because he was saying to me, Pat, it's hard enough to find a place to sit down during the day when you're homeless, much less to sit down and start taking stuff out of your pack, because that makes you a target on the street. So I would rather have somebody come and see me 3 times a week for a dressing change that they could be doing themselves because they're perfectly capable of it, but I want to reduce their burden because they don't have a safe place to do that. One of the other things is, we're all trained to practice evidence-based medicine, but sometimes the best evidence isn't going to fit with the individual's circumstances. An example of something that I ran into was I had a patient who needed surgery for a 3rd metacarpal fracture, and the provider put them in a removable cast because that's the standard of care for that particular problem. And unfortunately, he would take it off and play guitar, and he would take it off and put it back on, and he'd take it off because he wanted to go outside or do something different, and then he put it back on, and it was like on and off 100 times a day, so it was never doing what it was intended. So thinking about person's capacity to really understand the limitations of this removable splint is a big piece of figuring out what's the best thing for the person. In his case, a cast would have done much better, and probably he would have been healed in less time if they'd put a cast on and just changed it once a week so that they could do the wound care underneath. What else? Patient education, patient education, patient education, patient education. It goes a long, long way. And one of the things we try and do is teach back. I just was talking to somebody the other day. It's like, here's your this and here's this, and this is what I need you to do with it. And he knows well enough by now. He went back and said, okay, so I'm supposed to leave this on until it falls off. And if it falls off, then I have to put this on and this, and then I'll see you on Monday. It's like, yes. So getting people to teach back is a really great way to see if what you're communicating is being understood.
The things that come to mind for me are I never write a treatment plan that does not align with the client identified goals. And obviously this is from a mental health perspective, but that importance of including their language, their goals. I might have a really big interest in getting someone who is experiencing psychosis on some pretty regimented medications and seeing psychiatry, but that's not where they're at. So meeting them where they're at, and again, with that rapport piece, I think it can go a really long way in creating a successful treatment plan, because I don't want to take credit for their accomplishments any more than I want to take responsibility for their failures. I think a couple other things that come to mind are, I don't know if you guys know, but Oregon's foster care system is struggling at the moment. So we see a lot of folks in Stride who have been through 16 foster placements in a matter of 3 years. So each time a child gets placed in a new foster home, they're required to have a new mental health assessment called a CANS. So that's 16 times this one person has told their story in the past 3 years. So I'm not going to make this person meet with a therapist right away. So I think the peer model and having someone who can just meet with them and not write a billable note and not fill out paperwork for a couple of times can really help meet them where they're at, and takes away the power of insurance and the power of kind of that disease medical model, and just allow them to be themselves for a couple of times. Those are the things. And harm reduction. I'm not going to get everyone housed no matter how many phone calls I make in one day, and I will not have a great day that day. So looking at ways that they can stay safe and how they identify safety, because I have a very unique privilege lens of what safety looks like, and that's not the case for all of our clients.
All right, thank you so much. If it's okay with you, we'll take another question from the audience. What do the homeless describe as barriers to find shelter? And Pat, we'll start with you this time.
So one thing we try and do as much as possible is not call them homeless. These are people who are experiencing homelessness. They have identities that are far beyond their homelessness. So for those people who are experiencing homelessness, the things I've been told, there are lines, there are time restrictions, there are financial restrictions, there are adjudication issues. We have one guy who desperately needs to be housed. He's been living in a van for many years. He's lost a foot as a result of that. He's probably going to lose the other one fairly soon. He's got diabetes. He has some neurogenic problems. He has to self-cath because of his neurogenic problems, so he gets multiple urinary tract infections. He doesn't have an address, so it's difficult to get things shipped to him. So his barrier is because he has a couple of felonies, nobody will take him. There's just no place we can put him. So there are so many different barriers, but they're unique to the individual. So it's really about finding out what their circumstances are and then trying to help them find appropriate shelter. I had a guy who would rather sleep at a bus stop than go into a shelter, because every time he went into a shelter, he was victimized because he is on the autism spectrum and doesn't quite interact the same way as everybody else. So people would go and steal all of his stuff, and it was easier for him to sleep at a bus stop sitting up than it was for him to be in a shelter. So trying to help people, trying to identify what they consider the barriers and then working around those. He's in an apartment now. We were able to help him, secure that. But there are so many, it's kind of too numerous to mention in my experience with it.
So yeah, so many barriers. Criminality can really be a difficult one to come over. If you're somebody who's been in prison for 20 years and you get out, there's just so many pieces to that, to transitioning to so-called a place to live in a safe place. Poverty, folks just don't have the money. They don't have the way in. They have other priorities right now. They're just trying to eat. They're trying to keep themselves safe. They have a dog. They have their friends out on the street. I mean, that's where it's at right now. Yeah, there's so many different levels and layers and different ways in. So being available for the different things, I don't know. I'm getting lost.
I think also location, like if we think about it, the way folks find home opportunities and housing opportunities is either through education or employment. And in order for folks to be housed, generally in the Portland metro area, most of those places for adults are in downtown Portland. But there are jobs everywhere. So having to commute to and from the shelter where you don't necessarily know if you will get a bed that night, but you do want to make sure you get to your job the next day, because that gives you a sense of identity and purpose. I think breaking down that idea of what a typical day looks like when you have no idea where you're going to sleep that night, that kind of clouds and is a unique lens to so many people's lives that it's hard for them to see beyond that.
One other comment that comes to mind is what my supervisor refers to as rehousing syndrome. For some people, after having been on the street for so long, suddenly having four walls and a roof is a very disconcerting thing. What has been known to them, what they've used to survive for so long, having a roof becomes a very foreign experience. And it takes, and there's a sense of unworthiness that goes along with that. That makes it very, very challenging to have this major change in your life. As much as we might think it's a great thing, for many people it's something to kind of work towards. And that's one of the things I love about my Health Connections program, because we've had a couple of people go through there and into housing, and they were in our transitional spot kind of long enough to work through some of that so that they're being more successful in their new homes.
All right, wonderful. Thank you so much. We'll move on to another question. You've already touched on this a little bit, but if you could elaborate, that'd be awesome. Where would you find resources for these individuals to access?
So in lovely Portland, Oregon, we have this lovely thing called the Homeless Youth Continuum. So it's essentially a low barrier, no wrong door access point for young adults to access supports through different agencies throughout the Portland metro area. So the HYC is very lovely. We work a lot with the HYC. They have primary care supports, they have housing supports, case management supports, mental health supports. But again, those are all mostly based in downtown Portland. Otherwise, you can call Stride.
I definitely rely on the agency that I work in at Central City Concern, and just continuing to update myself on what our services are, as well as other community partners like Transition Projects Incorporated, Join, Outside In. Home Forward is a huge chunk of low-income housing in our community. I also listen to my patients, and they educate me a lot on just what's available, what's going on, how much value they receive from the different services. I think that's probably one of my best go-tos is talking to folks about, what are they getting from the different programs and how's that working for them.
With my new role over at Health Connections, I've done a fair amount of care coordination. So my Wednesday mornings are often spent making a lot of phone calls, trying to figure out how to facilitate all the different connections that are needed to sort of surround somebody with the care that they need. One of the things that I turn to a lot is the Rose City Resource Guide. It's published by Street Roots. I don't know if anybody has seen it. It's a little book that's got all kinds of information in it about pretty much anything anybody could need at any given time. In Portland, we have 211, which is another resource. It's 211 is kind of like the 411 for non-phone numbers. It's about resources. Transition Projects has the Resource Center, and you can sign up at the Resource Center and get a case manager, and somebody will help you navigate a lot of different things. We started a thing called a CHOW, which is a community health outreach worker, and this is somebody who actually goes out and helps people with insurance, how to sign up for insurance. It helps them navigate the different options. They can do intake paperwork for new patient appointments at Old Town. They can get their appointment with that person. We have insurance assisters who are at different locations throughout the city, and they're helping people access insurance. The only barrier there is if the person has Medicare and they need to get a secondary insurance. That has to be done through aging and disability. I think runs the list of everything I have access to.
All right, thank you so much. So kind of a segue from that question, we have another question from the audience. Are there providers that go to the housing insecure population instead of having them come to you?
Why, yes. I happen to be one of them. There's a street medicine group. They're actually meeting today. They wanted me to meet with them, but you guys got me first, so I'm here. So they're actually going out on the streets and doing some street medicine. We run a clinic in the Transition Projects Resource Center. There's an organization here whose name is escaping me. One of you here, I'm sure, knows about it, that goes over to the Clark Center. It's a student-based organization. Bridges, thank you. The Bridges Care Collaborative with the other BCC. And then we are working on developing more shelter-based programs. So there's the Hanson Clinic. Eventually there's supposed to be 2 other sites that are opening up, but I can't speak to those yet because they're not secret, but they're not officially established. So there is a lot of work and a lot of movement towards that.
Sort of on the flip side of that, because I think that's great to go out to where people are, and I also don't think that's enough. I think it's important for our systems to really be as low barrier as possible. So at Old Town Clinic, we recently went to walk-in intakes. So you really want health care, but we made you an appointment for 3 weeks out to do your intake appointment. And you don't know what you're going to be doing in 3 weeks, so you don't show up. So our no-show rate was very high, so we turned it to walk-in. It's awesome. People just walk right in, start filling out paperwork, sit down with an intake coordinator, get integrated into the pharmacy, can either go to urgent care services or see a provider in about a week to 2 weeks. So I'm really interested in that. That feels really important to me because you can do stuff when you go to their camps, you can get to know people, you can build rapport, but it's not a replacement for really getting that kind of ongoing care that should be everyone's right in primary care.
With LifeWorks Northwest, the STRIDE program, we go to you. So we're a tri-county community-based program. So our barrier is pretty low. ESA is also that way, as well as if you meet level D criteria, you can apply to be part of the TAY program, and that is just a higher level of mental health care, and again, they go to you, and folks experiencing homelessness are eligible for that as well. LifeWorks also recently switched to having walk-ins at various sites at various times, so you don't have to wait 3 weeks out to see a mental health provider. At 4 of those locations, there is some primary care offered.
One thing I should add is at the locations where I'm working and that we're developing these locations, it's adjunctive to primary care. It is not a replacement for primary care. Part of every single intake is where are you getting your primary care? And my most common answer is, well, I have OHP. And I have to explain to them that OHP is a form of insurance. It does not mean primary care. And I'm here to help facilitate that, but let's get you directed into primary care at whatever location is going to be best for you. Of course, I'm biased. I want them to come to Old Town Clinic because it's easiest for me, and then I can have this kind of ongoing relationship as a result of that. But if they want to be at Providence, they're at Providence. If they want to be at Adventist, they're at Adventist. It doesn't matter to us where they want to go. The point is that we do what we can to facilitate access to primary care and get them established.
All right, thank you so much. I think we have time for one more question. So we'll take another one from the audience if that's okay, and Nora will pass the mic back to you to start. Is there something unique regarding homeless veterans? Are there extra resources? Are there extra challenges?
I have no idea because we don't have veterans in our program that I know of. So I'm going to look to you two.
We have veterans that don't get veteran services in our programs. You know, maybe they had a dishonorable discharge or they're not, you know, they don't get benefits. So we see some folks in that sort of situation, but I'm not as skilled around veteran services. I could make some stuff up, but I don't have it.
And I barely have more than that. I happen to be married to a veteran, so I know something about that from his experience being a son of Uncle Sam, as we like to say. And with veterans, their experience with the service will in many ways dictate whether or not they love the services that they get or they hate the services and they don't want anything to do with it. So I've had people from one end of the spectrum to the other where their experience while they were in service was so horrible that they want nothing to do with the VA or the Veterans Associations or anything to do with the military, despite the fact that they could get some pretty good benefits. For example, one of the problems our folks have is that they can't get identification. You know, you have to have in order to get any kind of identification in Oregon, you have to have a birth certificate. If you don't have a birth certificate, you can't get identification. So there's a mismatch there. If you're a veteran and you've got your, your DD-214, you can go into the VA and they will give you a form of identification that works because you're a veteran. If you're a disabled veteran, you get even more services. But if you hated the service and you don't want anything to do with it, then you're going to go and do something else. Right now, I've got a guy who's living over at my Health Connections program, and he loves the military. And he had a good experience with them, and he gets all of his services through the VA. And then he sees me for, I cut my finger. So it's very varied, and it really, you have to honor where the person's coming from and what their experience was and whether or not they want to access those services, because they may or may not. But there are additional services available. However, they're also kind of overrun. So it's a mixed bag.
Okay, thank you so much. I think that concludes all the time that we have for this session. But before we all break again, everyone